6-year program. We do 3 months of research every year and a half. Most of them are 7. Yeah. I don't know. It's interesting. She still take call. For children out. Right? Yeah. Have we gotten proton therapy yet?
No, we've got a couple of years.
A couple of years.
What are your thoughts?
Is that, am I open again once?
That is nice.
I just don't know anything about it. And then I haven't been on breast or journal club or anything. And one of my friend's moms got diagnosed with breast cancer in her house.
I left at 7:20.
So she got a mastectomy.
Yeah, so I got it.
Or sorry, she had a lumpectomy and she all that stuff. They're gonna offer her proton therapy. So I remember asking.
It's just, I didn't realize.
I'm pretty sure. Now this is months ago, but I was like, I don't really know anything about
The
it.
University
So
Avenue.
I emailed Dr. Parker and was like, you let me know when the next breast or journal club will have these. Yeah, I'll let you know.
Parking is like the interesting one, because there are a couple cities where it's open.
Yeah.
Oh,
But
think it's just been crossing.
there's some other ones where you're like,
Yeah. I don't know if it's fast. Well, I just looked at it just on working in my lot, but.
Yeah, like,
oh,
I'm not saying it's not the rest of my day, I'm not at the front.
yeah. Okay.
I'm very excited.
Yeah.
So I'll be
Right. Exactly. That's what I was like, we didn't have that UAV yet, so I don't know.
Well, good morning, everybody. Thanks for coming to our spooky Friday the 13th Fellows meeting. So we've got 5 T32 presentations to get through today, so we're going to try to go ahead and get through. Hopefully we'll make it to 9:30, and that'll be it, and I won't have to hold you any longer. But that's pretty much it. They were drawing straws to decide who was going first. I don't know. Okay. Here we go. I'll do all. Oh, here it is. Okay.
Okay. I'm Audrey Wallace, and today I'm going to talk to you guys about radiation therapy decision making in early stage breast cancer patients, looking at clinical trial data versus real world data. So I'm a 5th-year resident in radiation oncology, and I'm one of the postdoc fellows. I'm interested in decision making in kind of 2 different areas, but primarily older cancer patients. The project I'm going to talk to you today about is breast cancer. I'm also doing a palliative care project. This is 15 minutes, so we'll just stick to breast. Unfortunately, my mentors couldn't be here, but Dr. Rock in medical oncology, she's absolutely amazing. I've been working with her since I was a first-year resident here. Dr. Levitan's been great this year in terms of methods and just kind of career guidance and advice. And then Dr. Oliver, I've known since med school, and she's really my palliative care and my decision-making mentor. So when you think of breast cancer, we've had a dramatic shift in the last 40 years in how we treat these patients. We used to treat them with these large, morbid, disfiguring mastectomies. Then we had clinical trials that said you don't really need to do these large surgeries. You can treat patients with what's known as lumpectomy, which is a smaller volume surgical procedure. But you need to give them radiation after that lumpectomy, and that lasts about 6 to 7 weeks. That's known as conventional radiation. Same time, we started realizing that you need to block hormones because estrogen and progesterone are the 2 big drivers of breast cancer. Then we had 2 primarily big trials out of England and Canada that suggested that we could actually give shorter courses of radiation. So instead of the 6 to 7 weeks, I can give 3 to 4 weeks. And then as we had increasing data on use of hormonal blockade, there's thought that maybe you should even give it for longer periods of time because we've moved away from thinking that breast cancer is really a surgically defined disease, but more of a systemic disease. More recently in the modern time, in older women that have, small favorable breast cancers, there's 3 trials now, one that came out recently last year, that suggested that maybe we can completely omit radiation in these patients. But that comes with a caveat that you have to be compliant with your hormonal blockade. You actually have to take these pills every day for 5 years at a minimum. This has led towards, guidelines being issued by various oncologic organizations. This is an example of a guideline aimed at providers. So NCCN is our, UAB is actually a member of NCCN. This is one of the bigger oncologic organizations that spans specialties. This is the breast cancer guidelines. And basically what they're telling us here is that hypofractionation that I mentioned, that 3 to 4 weeks, is what you should consider in most women. In the older adult oncology, they mention again that you can omit radiation in older women over the age of 70 with small volume favorable breast cancers, as long as they're likely to complete 5 years of endocrine therapy. So they're going to take that medication. We've also started to bring patients more into this conversation. The Choosing Wisely campaign is their guidelines aimed not just at providers, but more for patients to become more involved. So this is an example of guidelines issued by ASTRO, which is the American Society of Radiation Oncology. That's the governing body for my specialty, encouraging folks to realize that if you go to your doctor and you've heard that your mother or your sister or whoever it was got longer courses of radiation, it's still okay for me to offer you shorter courses. The evidence supports it, and it's less of a burden to you because you don't have to come for daily treatments for radiation Monday through Friday for 7 weeks. You can do that for 3 to 4 weeks. So how have these guidelines, what's been the uptake with these guidelines? So there's 2 big claims and population-based analyses data sets that are available. This one's the NCDB, and it represents about 60% of cancer patients in the U.S. Hypofractionation, which is that 3 to 4 weeks, there's poor uptake. In 2011, there's only 23% of women that were offered this. Poor uptake of omission of radiation, 75%. So only 25% of patients over the age of 70 are foregoing radiation. In another data set, which is SEER Medicare, that represents a little bit under 30% of cancer patients, only at specific sites. It's not as inclusive across the U.S., but this has been around for quite a long time, and it's a pretty clean data set. Again, poor uptake of guideline recommendations. You have a quarter and about 2/3. So we're not seeing physicians, patients, health systems pick up these guidelines as much as we would like. So what I wanted to do was, in a more modern era, look at it a little bit differently. When people look at guideline concordant care, they look at, did you get radiation? Were you compliant with your hormonal blockade? Nobody's really looked at both of them together. So I started with hypofractionation because if I'm going to omit, I should at least be offering women hypofractionation. So as part of the Center for Medicare and Medicaid Innovations grant, where we were looking at lay navigators, we had access to Medicare data at 12 sites in the Southeast. They're in 5 states. They're a nice representation of urban, rural, community, and academic centers. So from 2012 to 15, we had 671 Medicare beneficiaries over the age of 65. They had early stage breast cancer and they were treated with radiation. As you can see, these are an older group of patients in their 70s. And this is a measure of their comorbidities. So half of them had a fair number of comorbidities. In this population, 3/4 of them were offered adjuvant conventional radiation. That means not hypofractionated. This is the long course of radiation. So then you look at omission. So I looked from 2012 to 2014 in 800 patients. These are actually earlier stage patients. But again, the median age of 73 and the Charleston Comorbidity Index is not that different. Radiation was offered in 64% of these patients. So as you can see here by age, the radiation is the darker and the no radiation is the lighter. So as you can see, as a proportion of patients that get radiation, you do start to omit more and more. It's about 2/3 here. But when you look at the patients that you omit radiation on, when you looked at Medicare Part D, almost 60% of them had not a single instance of having filled a prescription for hormonal blockade. There's no trend for omission with increasing age, but comorbidity is more likely to omit radiation. So I'm going to take you back. I mentioned there were 3 trials that led us to the point where we can talk about having omission of radiation. This is the first trial that came out. We don't use this trial in our specialty as much because they had younger patients. In this trial, they actually reported that 20% of patients discontinued. This is the primary trial that we use. This has long-term 10-year follow-up data. The study did not rigorously capture tamoxifen discontinuation, so I can't tell you what percentage of my patients were compliant with their hormonal blockade. This is a trial, Prime 2, that came out in the last year. Again, limitations of our study is the lack of detailed information about adherence to endocrine treatment. So in some ways, we've kind of just jumped on the bandwagon of maybe we should consider omission of radiation without considering compliance and how that plays into this. So anybody remember who this is? Yeah. He was one of the more outspoken Surgeon Generals that we've had, and drugs don't work in patients who don't take them. And in this case, it's very true. If they're not going to take their hormonal blockade, it's just not going to help prevent their local regional recurrence. So adherence is a complex problem. When you think of clinical trials, about 4% of patients are enrolled. In the older population, it's about 2%. So I'm taking data from these, 96 to 98% of the population that they're not represented in clinical trials, and I'm taking this data from this small subset and applying it. And as you can see with the population-based analyses, that doesn't always translate. Even within clinical trials, when you look at studies where they looked at adherence with chronic medications, half of patients are not. When you look at specifically population-based studies of hormonal blockade, half to 2/3 are compliant, maybe, but discontinuation is very variable. So I would honestly venture and say if I had to, counsel my patient, I would say half the time you're not going to make it to your 5 years, realistically. So why does this matter? When you're thinking of somebody who's older, much of what I'm doing doesn't really impact survival. What it's doing is impacting their morbidity, their quality of life, and the risk of recurrence in the breast and in the regional lymphatics. It's not really a survival question. The trials that looked at omission of radiation, I'm not impacting survival. What I'm impacting is the risk of recurrence in the breast. You're looking at a 2% recurrence if you're compliant with your medications and you get radiation versus 10% risk at 10 years. So, we don't do this as much in breast. In prostate cancer, I think this concept's been around a lot longer, incorporating life expectancy. But if I take a 70-year-old woman here with a life expectancy of 16 years versus 80 at 10 and then 85-year-old at 7, that discussion of do you think you can add yet another medication every day for 5 years to your regimen of whatever other chronic medications you're taking? Because you guys saw that half of the patients already had multiple comorbidities, and a lot of those are cardiovascular, which means there's a blood pressure pill, there's a statin, etc. So that's something that you really have to consider, and we haven't been doing much of that for breast cancer patients. So how do we incorporate this into decision aids? Decision aids haven't been used on a routine basis in clinical breast cancer. This is an example of decision aid that was created back in 2012. And this is based on the results of that second study I showed you in that table of 3 studies from Canada. And the point here is that if you show this picture to women, they're going to think that they're going to be compliant with their medications because automatically all that matters is your risk of recurrence. It's not really that this recurrence did not take into account who was able to be compliant, who was not. So the numbers, the dark purple that you can see here is very small. But the bigger point that I'm trying to make here is that there's no discussion of what happens in the real world versus what you see in a clinical trial when you're counseling patients using a decision aid. So the gaps in the literature for these older women are, we've talked about these guidelines that are out there. Are they aware of these recommendations? Are they even interested in knowing about them? Do they want to know when I show them a decision aid, what the risk was in the trial versus what my population-based analyses show? How would knowing what happens in these 2 settings change their decisions? And how should we communicate this information with them? So as part of my projects this year, I'm doing a qualitative analysis. We're going to take women up to 20. They're going to be over the age of 65 with early stage breast cancer. We are only going to include patients who had lumpectomy plus or minus radiation in the last 5 years. And I'm not including patients who didn't have that discussion of omission of radiation with their clinicians. So within a consult note, when we see a patient and we counsel them on what our recommendations are, we typically cite that we discussed omission of radiation, but the patient decided that they wanted to go ahead and move forward with radiation. And the most common comment is that because they have, longevity in their family, they're interested in being as aggressive as they can be. So if that isn't stated in the consult note, I'm not going to go back and contact these patients to ask them to be part of the study. What we're going to do is, after consent, we're going to capture basic demographic data. I'm going to use the control preferences scale, which is a validated instrument, and then we're going to do face-to-face, semi-structured, in-depth interviews. And we've created these interview guides based on discussions with our medical, surgical, and radiation oncologists, psychologists. And also, this is the second part of a project that I tacked onto. I wanted to do this. Initially, Dr. Rock was just looking at metastatic breast cancer patients. So I've been part of those interviews, and in some ways, they've been helpful in helping us change our interview guides. A metastatic breast cancer patient is a little bit different than a patient with early stage breast cancer, because that's, when you're metastatic, your survival is finite, but when you have early stage breast cancer, when I'm thinking of taking another pill and I know that I'm really not going to die of this breast cancer, I'm likely going to die of whatever other comorbidities, whether it's my blood pressure or diabetes. So it's been helpful in some ways, knowing what some of those patients said, because some of that information is useful for early stage cancer patients as well. So what we're asking, a couple different things. We want to know about their previous decision making. So I'm going to ask them why they chose to have radiation, how much discussion did they have about hormonal blockade at the time. And the reason I'm doing that is because there are qualitative studies that show medical oncologists routinely dismiss difficulty with compliance with hormonal blockade. We emphasize the importance and side effects of chemotherapy because they tend to be severe, although they're a short duration. But we minimize the side effect profile with hormonal blockade because they're usually low grade, even though it's something that you're going to have not just for one day, but if you're going to be compliant, you'll have that side effect for 5 years. I want to know, when they're making these decisions, what do they want to know about their treatment? So were they physical, about recovery time, side effect profiles, practical considerations, impacts on their family? If they're older, do they have to consider, were they watching children, for example, that they have to think about in terms of treatment? Because like I mentioned, radiation is Monday through Friday daily, so you actually have to come into our facility to be treated. Financial considerations, something we don't consider, but financial toxicity is very relevant and important on the part of a lot of patients when they're making their decisions. Emotional considerations, looking at quality of life and well-being, and spiritual considerations. Those are essentially in every single metastatic patient interview we've had. That's come up every single time, so we know that's important. Future decision making. So how, now that you've described your previous decision making process, what do you think is important going forward? Because they still have to make the decisions to continue with their hormonal blockade, to come back in for their surveillance mammography. So what's important? Guidelines. So in terms of guidelines, have you ever heard your physician talk to you about guideline concordant care? If your physician actually recommended something that was not with guidelines, would you even care? What's interesting about this is I can tell you with the metastatic patients, preliminarily, through and through, it seems like the patients just don't care about the guidelines. What they care about is that you as a physician know your guidelines and that they can trust your interpretation of the guidelines. So I'm curious to see if that continues on with this younger cohort, not younger, but the less invasive cohort of patients. In terms of prognosis, in metastatic breast cancer patients, we were asking them, do you really want to know what your prognosis is? Because for them, we're talking about 1 year survival. In these patients, we're talking about 5 and 10. Do they even want to know that? And why or why not? And do they talk to you about your prognosis? And who actually talked to you about your prognosis? Because a lot of this in early stage breast cancer is very interdisciplinary. You do have a surgeon, a radiation oncologist, and a medical oncologist, and their perspectives are different, and their biases are different, and how did that play into this? And information delivery. Do you want to know what other women who've gone through this experience, what their experience really was? Do you want to know about regrets they have? So for example, if somebody chose to omit radiation and then wasn't able to tolerate hormonal blockade, do you want to know that? Because it's not routinely, it's not something that we share with patients when we counsel them at the time of consultation or in a decision aid. Then how do they want that communicated back to them? As far as methods, we're going to use grounded theory approach, but utilization of inductive process for our data analyses. We're going to take our transcripts, we're going to code them for the key concepts, we're going to operationally define them, and create a code book. Myself and another colleague, we're doing the interviews, and our plan is to simultaneously code and analyze, and after every 2 interviews, we plan on meeting and looking for themes and thinking about if we need to alter our interview guide. And we're going to look at agreement between us, UNSCO, and SCAPA. And that's it. Any questions? Yes.
I'm so sorry I came here 7 minutes late and I missed the first 7 minutes. The beauty is I learned a lot about the background, committees and that and so forth. Since I missed the first 7 minutes, what are you trying to accomplish with your step? And how can this crew be helpful? Because it was an amazing sort of the story about what's happening, the guidelines and the evolution and so forth. But since I missed the first few minutes,
I'm trying to decide whether I can incorporate information about real-world data and guidelines into a decision aid for patients at the time that we counsel them for treatment. Because we routinely don't do that.
So can you repeat that again? What you are trying to do?
So using a decision aid when we counsel patients at the time of consultation, can we talk to them about guidelines, and can we talk to them about real-world data that we get from big databases? They just weren't available even 5 years ago to the extent that they are now. So.
2 suggestions. One, I would look at what Dr. Sag had done in collaboration with Kaiser in Iowa. Was a study called Pattern, P-A-A-D-R-N. It was with guidance on treatment for osteoporosis. They use a bunch of different work. And then I would also look, I think it's Melanie Green, but it's basically narrative storytelling that they had done with people looking for treatment for breast cancer. And basically it's this idea that the patients want to hear from other patients. But if there's a way that you can incorporate that, having the patients give this kind of information and data. It's a lot of work, and it'd be worth talking with Dr. Sag about.
Okay, will do. Thank you.
So this was fantastic. I'm sorry I was late too to miss the beginning, but love what I saw. So in terms of building on some of Ryan's, thinking about next steps after these qualitative interviews, have you thought about what is the next study to move you towards this decision kind of tool?
So I actually applied for a foundational grant for this a couple weeks ago, and the next step for me would be the decision aid. So I'd have to test that decision aid out in patients to see what do I include, what do I not include. I can't just put it in the decision aid and say, here it is. So the next step would be to incorporate that into the decision aid. The next step after that is we're kind of moving in terms of decisional, providing the information that we provide to patients, not just being so many patients have recurrence, this is where you fall, but more of an individualized risk assessment for them. And for that, it's kind of a couple steps forward because I have to actually use machine learning to be able to incorporate what I want to do with the decision aid and use population-based data to do that. But that's kind of the next step.
Yeah, no, one suggestion is to consider, I think Sarah Knight's done a lot of this work and others have adopted in terms of this discrete choice experimentation. So thinking about modality of delivery, do these older women want something that's technological? Do they want a peer mentor? And have, so thinking about ways that your qualitative interview might even guide not just the decision aid content, but how it's delivered, where it's delivered, who it's delivered by, just to think about. I mean, it's a neat methodology that's used in kind of behavioral economics that helps not just with the content, but the modality of delivery. And someone else that might be good to talk to is Ellen Eaton. So Ellen Eaton's done had a lot of interest similarly in kind of guideline supporting care and HIV. So there might be some things that she's thought about that might be really relevant, not content-wise, but just thinking in this space.
Sure, thank you.
This is tremendous.
I do enjoy a lot of what you presented, and it's new information for me, so thank you. A couple of things. So one is the content of your study design, and so forth, and that's where you have your mentors, ideas, and connecting. Along that area, if decision aids continues to be sort of the main focus of interest, I would encourage you to look at the information from the Mayo Clinic folks.
Sure.
It's decision something.
Yep.
Victor Montori is the Peruvian guy who has been the leader on diabetes care and so forth. If you're perhaps there's a journey there that you can say, hey, perhaps I can do that. I'm a little bit worried about the extensiveness of your qualitative data.
Okay.
All of that piece of information is just very important, super rich, and so forth. The worry is, are you trying to bite too much in the first sort of serving? Just for you to think about that and consider.
Okay. The hard part about this is we really have three cohorts for this. We have the older breast cancer patients, kind of a younger breast cancer patient, and the metastatic. So what I'm trying to do with this is kind of be able to compare, have some level of cohesion between the three. So I understand what you're saying. Like for this, I wouldn't even be asking as much about future decision making, but we did so much of that with the metastatic that we wanted to at least ask something about that here. So I totally agree with you. If it was me, I would just be focusing on the past, the guideline, but I think in the bigger context, I'm trying to at least get a little bit of information about all the aspects that are in the other two cohorts. Yes, ma'am.
So I'm medical sociology, so you know where my questions are coming from, or actually comments. I think it would be really interesting to see the cohort differences that in that 75-year-old group that they probably, I could see a lot of them saying, I don't want to discuss this as a decision that we do together. You tell me if this were your mother, what would you do, kind of thing.
Yeah.
But I think as the years go on, we're going to see a shift. So that would be very interesting, and you look like you could continue this work for a long time. The other thing is on the qualitative where you had, I think it was emotional well-being. Do you think you can tap into how concerned they are about their appearance? 75-year-old women still do care about their appearance, and I wonder how much that will come up.
Yeah. Oh, I'm actually, one of the things I do plan on asking them is about cosmetic outcome, because are they even, younger patients tend to be very concerned with that. They're conflicting in the older population when you look at the data, whether they're as much interested about that or are they more interested in avoiding a surgery that would require a hospital stay of several days versus outpatient, go home the same day. So I am asking about that.
Okay.
Yeah, I think contribution is fantastic.
My name is Fabrice Julian. I'm a PhD student in medical sociology, and my talk today is from a thesis and manuscript I've been working on, and it's entitled The Association Between Perceived Discrimination and Depressive Symptomatology Among the Children of Caribbean Immigrants. So, how are different immigrant experiences related to perceptions of discrimination? And furthermore, how is the subsequent perceived discrimination related to mental health outcomes? Well, these questions guide my research investigating the association between mental health and racial and ethnic disparities for 4 U.S. immigrant groups. Now, these immigrant groups who we're interested in are comprised of white Cubans, Hispanic Cubans, Black Antillians, and non-Black Antillians. The first group represents immigrant youth whose families come from the island nation of Cuba, but who self-identify as white in the United States. The second group, also individuals whose families come from the island nation of Cuba, but who self-identify as Hispanic. The third group represents immigrant youth whose families come from island nations in the Greater Antilles, specifically Haiti and Jamaica, and the Lesser Antilles as well, comprised of various predominantly black island nations, but who self-identify as black in the United States. And finally, our last group are individuals from those same nations in the Greater and Lesser Antilles, but who identify as either white, Asian, multiracial, or other in the United States. So this is a polled group. Now, why am I particularly interested in these groups? Well, it's known that adolescence is a period in which the individual schema of the surrounding world is still developing. So this makes this time period a vulnerable time to experience something like discrimination. Now, why would discrimination take place? Well, to understand why it would take place or how it could take place, it's important to look into the concept of occupied status. Occupied status refers to the place in society that an individual or group of individuals hold. So for the 4 immigrant groups, a difference in occupied status is observed. In particular, we see that difference between the Cuban sample and the Antillean sample. But then we also see that there are differences within the samples themselves. Now, you can imagine that, well, in particular, Alejandro Portes speaks on this. He notes that the black Antillean sample, upon immigration, assimilate into predominantly African American or black neighborhoods. Now, these neighborhoods represent what he discusses and refers to as a relatively disadvantaged status. Conversely, for the Cuban immigrants, the assimilation that takes place is done in homogeneous or white neighborhoods that occupy what Portes calls a relatively advantaged status. So you can imagine that living under these different levels of status can translate to differential exposure to discrimination among other factors. So this sets up the all-important argument that Portes and McLeod end up making, which is that certain minority groups enjoy more privileges than others. So for the Antillean sample chosen, we're looking into them, I'm looking into them because they're an understudied ethnic group, and the Cuban population is selected because as a comparison group, they come from a similar region of the world, but live under different circumstances. Okay. So, on that, the mental health outcome that I'm interested in is depressive symptomatology. And its association with discrimination is interesting. There's a large literature that discusses that discrimination is negatively correlated to mental and physical health outcomes. The literature further speaks on increased experiences of discrimination contributing to the development of depression and depressive symptomatology. And we also know that as increased experiences of discrimination take place, perceptions of that discrimination are heightened, which can affect health across the life course. So in truth, experience and greater awareness of discrimination colors perception. Now, racial identity should also be looked into in the Caribbean because it's rather unique. So with regard to racial identity in the Caribbean, it can be a complicated matter. Each island with their own distinct history and colonization experience have unique ways of assessing race. Mint writes that West Indian society can be very easily misunderstood if you're applying traditional North American categories to try to understand it. And one of the reasons for this is because these Caribbean societies speak to the in-between, acknowledging that other race categories exist between and within black and white. So we also see that there's some preferences for these social identities, and Waters speaks on this, writing on the Black second generation immigrants and their racial identity preferences, stating that these identities become representative of power relations, with more power attributed to those who identify closest to white. So this really taps into the idea, the overall idea, that the lighter the skin tone with which one identifies, the less discrimination they encounter or perceive, and the lower their levels, thus, of depressive symptomatology. So the applicability here that we have for both the overall Cuban sample and the Antillean sample, we can see that in that white Cubans having a lighter skin tone than their Hispanic Cuban and Antillean counterparts are expected to be afforded more privileges, and Black Antillians potentially having darker skin tones than their non-Black Antillians and Cuban counterparts would have greater discrimination experiences or perceptions. So, looking for a framework where I can test these ideas so it can be better understood, I come to the stress process model, and it's going to be the central framework guiding this research. Now, the stress process model, it builds on Leonard Perlin's discussion on stress processes, and he posits that the statuses of people are potentially connected to virtually every component of the stress process, but that exposure to stress doesn't occur at equal levels throughout society. So, all the more, it's saying that within the stress process, you have individuals who possess a low number of resources and thus are at greater risk for compromised health. So having access to some of these resources like social capital, social support, close friendships, maybe even ethnic pride, can buffer against the negative effects of some of those stressors. So bearing this in mind, I create this stress process model here that is influenced by R.J. Turner, who also speaks to Perlin's stress process. And for R.J. Turner, his stress process model or version of it reflects a health outcome measurement strategy that assesses exposure, which, as I mentioned earlier, is known to be an increased risk for poor health. So the process that we see here in this model notes that racial ethnic identity can contribute to depressive symptomatology, and identity can influence the perception of discrimination, which can also enforce identity. But that perception of discrimination can manifest directly to depressive symptomatology. So with all that, 4 hypotheses are stated. The first being that perceived discrimination impacts one's depressive symptomatology, and that the greater number of perceived discrimination responses, the greater the depressive symptomatology. The next hypothesis is that the effect of perceived discrimination on depressive symptomatology varies by race and ethnicity. And then the remaining 2 hypotheses tap into kind of the literature that Portes speaks about with regard to advantage status, saying that those who identify as white Cubans will perceive less discrimination and will have lower depressive symptomatology compared to the other identity groups, and that those identifying as Black Antillians will perceive the most discrimination and will have the highest depressive symptomatology. So to test this, we used the Children of Immigrants Longitudinal Study, which Alejandro Portes created. And it's a longitudinal study, but there are 3 waves. And in particular, the variables of interest or the variables that are of most interest to us all happen to be in the second wave during this adolescent period. for our population. So there's focus on that second wave. So again, we're using 4 comparison groups for comparative effect, and those are the variables that we end up using, depressive symptomatology being the outcome variable, the independent variables being identity, perceived discrimination count, family cohesion, whether or not a family member had been a victim of crime, and then our controls being sex, age, time, income, and parent education. So our descriptive statistics note that the white Cuban population has the lowest depressive symptomatology score. This score is the CESD score, and that the non-Black Antillean group actually has the highest depressive symptomatology score. So that goes against our expectation. But then as far as discrimination count goes, the same trend is observed, with the lowest discrimination count being afforded to the white Cuban population and the greatest being afforded to the non-Black Antillean population. We run OLS regression and find that overall several of our hypotheses are supported, including the one that notes that the greater the discrimination count, the greater the depression score. So we end up having partial support. The first hypothesis is supported. The second hypothesis is as well supported. The third, what's interesting about it is, although we do find that those identifying as white Cubans perceive less discrimination and have lower depressive symptomatology compared to the other groups, although that's true, it did not have significant effects. And then finally, our fourth hypothesis was not supported. Instead of the Black Antillean group perceiving the most discrimination, it was the non-Black Antillean group. So some limitations. There could be some confounders that may be influencing one's decision to identify a certain way. So it's very possible that that could be explaining the difference, and those confounders could also explain the association between identity and depression. And we do not have a direct skin tone measure in this data, so a lot of this is implied. And going back to those identifying as non-Black Antilleans having the most discrimination, what could be explaining that is potentially a form of intra-group discrimination for not necessarily identifying in one way, still being a minority, but within the minority group itself being subject to some discrimination. There's a lot of literature on skin tone stratification that supports this. So some future direction and some ideas that should be explored. It would have been helpful if we had a comparison, or if we maybe could compare findings from now. So this second wave was collected in 1995. If we could maybe test this again in the 2010s or anytime in the 21st century, it'd be interesting to see if these trends continue to remain. What's of particular interest is the fact that these individuals, these second generation individuals, comprise a majority of the American workforce today, as they are adults themselves. So doing studies like this can help us to kind of understand trends of pre-existing depression levels with regard to that. Some acknowledgements. Dr. Patricia Drentia, who's been instrumental in helping me to conceptualize and think about this rather complicated concept, as well as doctors William Cocker-Ham, Dr. Mark Ligori, and Dr. Elizabeth Baker, who have sat on my committee and have been really helpful with giving me direction for this idea that I want to explore. So, comments, suggestions, and questions?
I may have missed this, but how is perceived discrimination measured? How is that?
Yeah, perceived discrimination, yeah, I didn't go into it, but perceived discrimination, originally, what I wanted to do was to create a scale. There are some questions within the data set that ask, have you ever been discriminated against? Have you ever been discriminated against by this group? So I attempted to create that scale. However, the Chromebacks alpha was too low because some of the questions weren't pairing together. So what was done instead was a count variable was created. So if the answer was it being a dichotomous variable of yes, no, I've experienced discrimination, yes, no, I've experienced discrimination from this group, of those 4 questions, it was just a scale of 0 to 4. So the more yeses, the more perceived discrimination they have.
Thank you for presenting in such a clear manner. As I understand, this is a historic cohort study. Someone gave you the gift, a the data set, and so forth, and that was articulated. Is that correct?
Yes.
You may or may not have this field in your data set, and that is, where do these kids land? So, 2 questions. Are they first or second generation kids, or where do they land? I have a very narrow perspective that perhaps people from the communities that you're trying to study may go to Miami or New York, but again, that's just my very narrow approach. Do you have that field of information?
Yes, so the population sampled come from Miami and San Diego. So those are the 2 major cities, and they are second generation children. So their parents came from those island nations.
Might you have other data fields that can help you understand and explain the context? If you go to Miami, I would presume your phenotype may be a little bit different as if you go to San Diego for things that may be outside your control.
Sure.
And I would sort of encourage you to leverage whatever information you have as to how do you explain within your conceptual model that you have, because they're going to ask questions like, what's the difference between the people? Do you have a self-selection approach, or was that sort of random creation, and so forth? So that will only strengthen your conclusions.
Thank you.
I'm taking notes.
Thank you very much. So with that figure you showed, it almost looks like this kind of Barron and Kinney classical mediation pathway. So just wondering, in your thinking, are you thinking of perceived discrimination as a mediator between identity and symptomatology? And have you thought about analyses that might look for that mediation? Is the first question. Then maybe look at the tables. And with those staged models, it seemed like there were some significant effects that became attenuated, perhaps suggesting that something that was added or the combination of factors explained or might be responsible for losing that effect. So just trying to wrap my head around, and maybe we can look at those models a little more closely. Might be some of the variables you mentioned, Carlos. Think about number 1, is this kind of mediation, or thought about doing some sort of mediation analyses? And then number 2, in evaluating those staged models when things lost significance, is there some suggestion of attenuation due to those factors might be contributing to what was seen in the prior model?
Yeah, so yeah, this is definitely a mediation pathway I've created here. So I will look into that and make note of that. What's interesting, there's also a hypothesis that is a moderating hypothesis where it's thought that perhaps the relationship between perception of discrimination and depressive symptomatology varies by racial or ethnic identity. So it's like it's a little complex.
It's really complex.
Yeah.
Are folks familiar with the distinction between mediation and moderation? Those terms oftentimes get used interchangeably, but they mean very different things. Do you want to help folks understand that distinction?
Yeah, so with the mediation pathway established up here, it's saying that the pathway from our racial ethnic identity to depressive symptomatology can be strengthened or decreased by one's perception of discrimination. So it's acting in either a positive or negative way. For moderation hypothesis, it would be that the difference between any of the two, you would draw a line from maybe the perception of discrimination box there down to the center, and would be saying that the differences are explained by what is going down that box. I don't know if that was clear enough.
Yeah, no, I think for me, sometimes the way I've thought about this is a mediator is really, it's no different mathematically, I think you can correct me, than a confounder, but it's on the causal pathway. So the distinction is, it's not a confounder. It's associated with your exposure and outcome, but not in a random way. It's the driver. It's saying the relationship between my exposure and outcome is through this intermediary. We're thinking about it statistically. A moderator, think about an interaction term. So a lot of times you'll see moderation done in the context of an interaction so that the relationship depends upon. So it's not through this pathway, but you might see a differential relationship between your exposure and your outcome based upon this factor and which where you are on this factor. So really important distinction. These terms get used interchangeably. They mean very different things, both conceptually but also statistically and epidemiologically. Thank you.
And each of these works is to learn from each other, not only about the context, but also other aspects that we may not have thought about. And so thank you for expanding on the mediation, on moderation, on modulation, on that stuff. So that I appreciate that. Several things that you did very well on your delivery and your slides. So one, it was concrete, pause, organized, and all tied together. I think we all saw that, we all read it. Two, your slides were clear, it used figures when it was needed, and the tidbit of information that I use in terms of amount of information is no more than 5 words per line, 5 to 7, and 3 to 5 bullets per slide. And I counted several times, and you were right on there. And a few other things in terms of amount, the pace, and knowledge, organization. So thank you for doing that. If you want to do it a little bit better, you may want to shade 1 or 2 words per line, enlarge the font a little bit, and change the font to a sans serif. It's just much easier to read here, and we can talk to you offline. And I'm sure there are 2 or 3 other things that you did extraordinarily well, or 10 other things that I just want to emphasize that for you and for the group. So, thanks for you and your mentors.
I was also thinking to reduce the regression table and just highlight the important parts. You all agree and blow it up?
That's a strategy. The other one is you can put a whole regression table, say, hey, there is too much information, and then you zoom in on 1 or 2 that you care about. So for example, I was curious. Cuban white family income, you said 10.4. Is that 10,000? Is that so 10.42?
Yeah.
Family income 10.42. I would presume 10,000, correct?
It's actually so it's a categorical variable with between 1 to 13, and 13 being the group where it's $250,000.
Wow.
Or over, or
So
something.
the idea is whatever, I agree with you. Sometimes it's too much information, but it's okay to be comprehensive, but then whatever you want to emphasize or ask a question, say, wow, this is, I feel that I pay attention to that one because I was thinking, is it poor people or rich people? Correct?
Yeah.
Thank you.
If it's okay, I think in the interest of time, we might just want to do one more presentation today. I just want to make sure everyone has the full time to discuss. So I think we're overly ambitious, and I apologize for that. If it's okay, would you guys mind? I just want to give you guys the full time to present, and probably 30 minutes per presenter is going to be good going forward, just so you can present and have ample time for discussion. So it's on you. I apologize. I don't know is anyone more? I don't see.
Or unless you particularly want to.
And then we have time, I think, in the coming weeks, we can make sure to get additional presentations on the schedule soon. And again, apologies. I think we're overly enthusiastic and ambitious. And
I'm sorry.
no, I think the richness of these sessions is we want to make sure there's time for the discussion because that's what the purpose is. Is that okay?
Yeah.
All right. Thank you. I appreciate it.
Okay. So I thought mine could easily follow Fabrice's. I'll be talking about HIV stigma as a barrier to health in the area, or in the era of treatment as prevention and pre-exposure prophylaxis. I'm not going to talk a lot about TASP and PrEP, but I like to couch it in that because sometimes when I talk to people outside of the health field, they sort of ask, why are you doing this work? We have all these treatments that work, and HIV is just a chronic condition now. And I say, well, if we had all the treatments that work, there would be no transmissions and people wouldn't be dying of HIV, and it's behavior that's really driving the epidemic. And so we need folks like me. I'm a behavioral scientist. I'm a clinical psychologist by trade, and doing some of this work to understand some of the social and structural drivers of behaviors that are driving the HIV epidemic. So I'm not so much going to talk about, oh yeah, happy Friday the 13th. It's another reason I wanted to go today, so I could get my joke in, but hopefully it's nothing more to you than just remembrance of this 1980s horror flick star, Jason Voorhees, who wouldn't go away. So I'm not so much going to talk about a specific project. I'm new to UAB. I'm coming from the University of Connecticut, where I finished my PhD. So I'm going to talk more about how I'm bridging my work from there to here, and where I could just use some help in terms of thinking about people I should be talking to or opportunities I should be taking advantage of and things like that. So I'll give a brief introduction to my work and background. I'll talk a little bit about my works in progress and the sort of trajectory of work I have going forward. Okay. So just to give a brief social psych refresher, when we talk about stigma, there's this societal stigma that sort of just exists in our universe for a variety of different dynamics of being humans or living beings. And they manifest in different ways and in cognitive ways where we sort of form these stereotypes or understanding of people who have perceived or actual stigmatized identities or traits. Prejudices that manifest in these affective ways. We have these emotional responses when we think of something as stigmatized, and discrimination is the behavioral manifestation of stigma or experienced stigma. And where this gets interesting for me in terms of measurement is this HIV stigma mechanisms model by Earnshaw and Chadwa that's been extended by my mentor, Bulent Tehran, to include this final thing. But we can understand this big sort of fuzzy stigma picture in terms of these mechanisms. So in terms of internalized stigma, the degree to which people who have a stigmatized trait apply these negative beliefs to themselves. So I'm a bad person because I have HIV would be an example of internalizing stigma. Anticipated stigma, the degree to which going into this situation, I believe that people are going to treat me badly because they'll think I have HIV or know I have HIV. enacted stigma being actual events that have happened. So this did happen to me where a healthcare worker treated me poorly because of my HIV. And then perceived community stigma. So just these general kind of global beliefs that people in general think that people who have HIV are bad. And what I'm interested in is sort of how this acts upon a person to affect these outcomes. So within their mechanisms model, they found all these kind of negative outcomes that stigma has on HIV acceptance, things like depression, antiretroviral adherence, medical clinic visits, CD4 cell count, chronic illnesses, health behaviors, and so forth. So this is where I'm interested in, having worked in a lot of these settings, where I get kind of frustrated. I know how to treat depression and anxiety. It's harder to do that when folks won't come in because they're afraid they'll run into somebody they know in an infectious disease clinic. Or if people are hiding their medications at home and forget to take them because they're afraid somebody might come over and see them, and so forth. So I'm particularly interested in, again, how this affects the person, and some of my hypotheses there, sort of that there's these stress processes going on where no one really knows how to cope with being stigmatized. We're not really taught how to cope with that. So people's coping resources get overwhelmed. They tend to default to more avoidant coping strategies. On the other hand, there's some good work on resilience factors or resources that might be protective for people, because not everyone who's stigmatized has these negative outcomes. Some people are resilient to them. But in my work, I found pretty strong associations between stigma and depression. The Tarans have done a lot of work on stigma as a predictor of antiretroviral adherence, which if you don't take your medications, your HIV can get out of control and you're more likely to transmit HIV, and has all these kind of complicating problems. And it's important to look at sort of what these drivers of that are. We have a paper that's in press right now on internalized stigma reducing likelihood of attending clinic visits. I found associations with folks who internalize stigma are kind of twice as likely to have a CD4 cell count that's kind of in the age range. So that's pretty important. I'm getting pretty interested in sort of comorbid and chronic illnesses that people have in addition to HIV, and how these stress processes might be affecting those, as well as health risk behaviors. I'm currently working on a paper looking at stigma and its effect on tobacco use in people who have HIV, because tobacco use is kind of out of control in the HIV population. It's like twice as much as the general population. So we have to look at some of the factors influencing that, and I surmise that perhaps stigma and stress and how people are coping with it might be driving behaviors like tobacco use. Likewise, my master's thesis work, I found associations between stigma and sexual risk behavior. So there's a lot of ways in which stigma can act on a person and sort of influence these health behaviors, and I think understanding the mechanisms of that, or mediators, is sort of where my work is right now. And this intersects with Mug's work. This is actually a slide from my dissertation. So where I'm particularly interested in is some of those downward areas where folks reporting stigma tend to be less engaged in care, at which point they can't really be prescribed their antiretrovirals to take them, and are less likely to reach viral suppression. And then my other interest there in sort of the medical comorbidities and where those might be coming in as sort of the next forward step in this model. So some overall lessons that I've learned in my work is, one, that we don't necessarily measure stigma well, and we do okay, but it is sort of this fuzzy concept, and what has happened is we often capture these really big events of stigma discrimination that happen in people's lives. What I think that happens with people who are stigmatized, it's oftentimes these little microaggressions that happen on a day-to-day basis, where it's like something kind of happened, you're like, did that happen because they were like thinking that I had HIV or something was wrong with me, or and it kind of takes up brain space. And I think that's really what's maybe impacting people on a day-to-day basis. But what we get at in a lot of our stigma measures, like Earnshaw's stigma mechanisms measure or Berger and Bunn's HIV stigma scale, are these like big salient stressful events, and they are impactful. We do see that they have an impact on behaviors and health outcomes, and they're important. But I'm increasingly interested in how we might get at measuring, thinking about sort of the micro day-to-day events that happen. I also think that if we conceptualize stigma as a stressor, we have to measure it as such. And we have some interesting work going on in our lab right now. We'll be looking at cortisol levels and sort of trying to tie that together with reports of stigma. I think that mixed methods work may help to expand upon perceptions of enacted stigma at the individual and group level. I particularly think this, having worked in clinics, and I just see stigma day to day, and I don't necessarily see that being borne out in a lot of the research that's being done. I also think we must use prospective and longitudinal designs. Much of the stigma work to this point has been cross-sectional and sort of hypothesizing these different potential causal models of what's going on to impact health. And I think the next step is really looking at this longitudinally. We also have to parse between sort of the intrapersonal and interpersonal, since stigma often happens at the interpersonal level, and sort of thinking how that might drive future intervention work, and so forth. And we also have to address the layering and intersectionality of stigma. In my dissertation, I really focused very much on HIV stigma and how that really impacts the person at the individual level. But I can't ignore the fact that HIV hugely impacts communities of color, people who are living in poverty, sexual minority populations, people who are affected by mental illness and substance use, and those other types of stigmas may certainly have an impact on health behavior and health outcomes. And this is just my little model of intersectionality. And there's certainly others that layer on top of this. My former mentor always said, I haven't found anything that HIV does not intersect with, except maybe autism. So the trajectory of my work is, as I see it, again, I think we have to get a handle on measuring stigma. One of my colleagues at UConn, Lisa Eaton, is doing a little bit of work on this microaggression measurement, so I'll sort of leave that to her for now, but I'll think about that later. Currently working on some prospective and longitudinal work and looking at this. We have access to the Women's Interagency HIV study data in my lab, and so that's a nationwide study at different CFAR sites where women complete surveys at nearly every clinic visit they come to, so I have sort of a range of data over time to look at stigma and how that might be impacting things like viral load or adherence, depression, so forth. We're also working on some geocoding to assess some of the structural variables on stigma, so different kind of census tract data, like what proportion of the community is living in poverty, what proportion of the community is on SNAP assistance, things like that. So we might be able to look at some of the structural determinants of stigma and health. Currently looking at intersectional stigma. It's another thing I'm not entirely sure we have a handle on measuring, but we're working on it. And also in the future integrating stigma material into intervention work and improving interventions by sort of having an add-on of addressing stigma and how people can cope with it, and already existing adherence interventions and so forth. So with that, I will end.
I'll give everyone a chance first. Are you ready? Okay.
Yeah, well, I know intervention is way down the line, but I'm just sort of curious, are there any interventions right now for stigma?
There are. They haven't necessarily been rigorously tested. And my lead on interventions for stigma is that I don't think, again, sort of going back to how we measure it, people don't report it a lot. I don't think people are necessarily motivated to go participate in a stigma intervention, whatever that is. But it's a part of everyday life. So I sort of see this sort of injecting stigma material into already existing interventions. But yes, there are, and there was a meta-analysis on existing stigma interventions. I'm forgetting the authors right now, but find it. But there are, I think a lot of what people do in sort of these stigma interventions is sort of community building and bringing people together. Janet Turan has worked on a healthcare discrimination intervention she's done in Kenya. They've done it here in Birmingham. Now they're doing it at some other sites around the southeast, where they're sort of bringing patients and healthcare workers together into groups to kind of have a kind of community board about how they improve healthcare and talking about how stigma affects patients and things like that. So it's sort of about just kind of building awareness and education about what's going on and getting perspectives from both sides to kind of build an understanding together. Yes.
Right, sorry, the last part. Love the idea. I think this field is just fascinating, not only for HIV, but obesity, this and that. And so I think it's fascinating. My comment may have nothing to do with pride, so please begin. On the other side of the stigma spectrum, is pride in that line? Because what I can think is, I have seen several of my patients with HIV with very well controlled this and that, and it's such a source of pride for them. I don't know where they began. I know they went to our clinic and so forth. That I'm wondering if there is something that we could learn from those in terms of pride that can sort of inform this area.
Yeah, I think it's a good point. I'm really interested in those people. I think that goes back to like the resilience factors. Like, is there something about their personalities or their social support networks or the way that they just approach stress, or somehow there's something about them that's very resilient to this, whereas on the other side, stigma tends to bring people down. So I want to see what lessons we can learn from those people who really take on, like, all right, I have HIV, I'm going to live the best life I can. And, I think that has to do with, cancer or other types of things as well. You get a diagnosis, you see some people who sort of take it on and fight, and some people that it really negatively impacts. So we have a lot to learn from them.
Just thinking about the interventions and even the framing of it, like I think you discussed these intermediaries of resilience and coping and things, and just the framing of an intervention as being something that is more of an empowerment and building resiliency and coping versus addressing stigma, and how that might be received by potential participants, and the framing is that as it goes forward. Because the interventions, I think, are not necessarily addressing stigma directly, but as you point out really nicely, it's, in the context of what you're experiencing at an individual level at least, how might have the skills to cope, have the resiliency. So one other question, I was really intrigued. You mentioned the kind of intra versus inter-individual variability. Mm-hmm. And you mentioned there haven't been a lot of longitudinal studies of stigma, and also the idea that it's global, not these kind of microaggressions. But is there a sense of the variability, and where there have been multiple waves with imperfect stigma scales administered, the variability of stigma over time?
Over time, I don't know. But the variability in general, again, tends to be, fairly low. So if you have these scales of have you been stigmatized or discriminated against, people tend to rate like, I kind of disagree that I have been treated that way. But again, it does seem to drive behavioral outcomes. So it's interesting.
And the reason that I asked, some of the work a colleague of mine, Brian Pence, who is like a behavioral epidemiologist, has looked at depression over time. And mathematically, and again, I don't know the statistics part, but it was really interesting that looked at the intra versus inter. So most of our models look at the difference. How do I compare to the rest of the folks in the room? And the idea that the variability over time in intra-individual depressive score had a huge impact on health behaviors. So my appearance, my sexual risk behaviors were influenced. So even though I might have a baseline score of 3 on the PHQ-9 and the median is 10, if I move from a 3 to a 7, even though I'm still lower than average, for me that 4-point jump has a big impact. So just thinking about, as some of this work advances methodologically, hopefully measuring this more micro, these kind of more day-to-day stigma experiences, even if someone has a low baseline kind of stigma, does a modest increase in an experience have an impact? So just thinking about opportunity, as you mentioned, that really kind of, that work that Brian did, I haven't seen done a lot in that space, and we're so often comparing how does an individual do relative to an average versus relative to themselves, and it really resonated. Just something else to think about.
Yeah, I think, there's a lot of opportunity to look at within person differences here.
Yeah.
Since you invest a lot of time in this space, I have a methodological question. I'm pretty new to this. How do you validate measuring something abstract like stigma? Like, what sorts of tools do you go about to really, support that?
People develop surveys, and so we administer them and look at how they work in populations and sort of how they relate to things that we think that they would relate to. So are we finding that these measures of stigma are relating to things like depression? Yes, so that sort of validates it. Are they relating to things like anxiety, social support, and so forth? So it's really sort of looking at what is that? What validity? When things relate to what you think they should relate to.
Construct.
There you go,
Yeah.
construct validity. So.
I would have, there's really no good way to validate a scale because I can create a scale for any particular thing, and a lot of times we find in research that the scales that were constructed for research only really well suit the cohort which they were constructed for. But having worked with a lot of cognitive impairment data, cognitive function, scale assessments, if you think that you have a few different good ways to measure something, what you can do, one way of trying to directly compare them is through like standardization. So you can do what's called a Z transformation. It basically sets it up on a scale where your mean is 0 and each increase is a standard deviation increase. So you're looking at kind of the population effect going from one, from what you would expect the mean to be through a 1 standard deviation increase, and then you can kind of directly compare them that way. But it's all kind of dependent on, again, the population and what they were constructed for. So.
I'm wondering, would it be a good topic for us to bring to it? Would it be? I mean, I think like someone like Bulent Turan, someone like knows psychometrics and development of scale. Would that be of interest?
Sure.
Okay, we can see about Bulent being added to the future because the whole science of it, and even like being involved peripherally with some of this work where you kind of administer, you do focus groups and then these kind of in-depth cognitive, even like with some of these scale development, it's such a science to doing it, and your points are so well taken that even once you do that, they have this is applied just to the sample of folks, and how do I extrapolate it? And that'd be a cool thing for us to maybe bring here.
We are currently developing a pro-stigma scale.
Yeah. I would say one thing to maybe consider when you're in the future when you're going to look at health outcomes, if you're already considering geocoding, that in addition to looking at like census tract, it may be important to look at access to care. So I know that like one of the doctoral students in equity is looking at diabetes care and management, and she's looking at social support and access to pharmacies and access to clinics. So you can, with geocoding, you can look at like those differences in how people have to travel to get care, and that may be a big impact on.
Oh yeah, hugely. This popular, and people often don't have access to transportation, so
sure,
living where we're living in. So very important. Yeah, it's a good point. Yes.
I think you mentioned this, but I may have sort of not paid attention. Are there any other group of populations where stigma is an important factor? I can think about smokers, obesity, any other sort of group of people or disease complex where stigma is
Addiction, I think. Addiction.
Addiction, thank you.
Where stigma is a what factor?
It's an important component of their pathology, self-efficacy, and so forth.
I would argue that race is also extremely important to consider.
What was that?
As well, race as well.
Race.
Ethnicity is extremely important to consider.
Sexual orientation.
Sexual orientation.
I mean, I think that a lot of those factors kind of compound the effect of stigma.
Mm-hmm.
I'm not sure much has been done in terms of diabetes and cancer, but I mean, I think there's probably, don't you think? I mean, stigma is somewhat pervasive a lot of times and across these different dimensions. I mean, I always get overwhelmed with this because I'm like, oh my gosh, I've got these 4 dimensions of stigma now according to this intersectionality. So I get this matrix in my head of I've got like these 4 dimensions of, yeah. So, I saw that. This is pretty, so this makes it much less scary to you. I have this 4 by whatever table of these, stigma domains, and then race, ethnicity, sexual identity, having HIV, but it's really such a complex field. And the intersectionality piece, I think, has only recently really been brought to bear,
Yeah,
like this in HIV.
I'm working on these intersection analyses, and we've been sort of looking at these different forms of stigmas as like moderators of one another, and that's just sort of how it's been done. And I don't know, I've been thinking a lot of like, is this the best methodological way to go about this? And what this looks like is, for some people, it's like asking sort of parallel items, like have you been stigmatized or discriminated against because of your race, sexual orientation, HIV status, using the same items, which has some problems and sort of bias of responding, or using separate scales for these various forms of stigma that have been somehow validated in the literature, and then you just have these different ways of looking at stigma, so this gets really complex.
So I can maybe try to give you a little bit of guidance in terms of like thinking about modeling. So try to like, create subsets of your variables of interest in terms of like the importance that you think that these variables are going to have the biggest impact on your association, and kind of go hierarchically down like through all, just in different groups. And that way, when you're doing your regression modeling, you can add those groups individually, and then if you're seeing these huge attenuations of your effects, then you can go individually and look at those individual variables within a certain group and say, okay, which one of these has the biggest impact on that attenuation of my effect? Mm-hmm. And so you can kind of parse out like what's having a bigger effect on your association than others.
Okay.
You could also consider latent class analysis, where you construct, or the analysis constructs groups like people who have high social support but low adherence. Like it'll create these different mechanisms for you, and then you can kind of parse apart like what's going on in different subgroups. So.
I love this slide. I'm so sorry. This is not for you, but it may not be for you. But anyone from the schools of health professions here? School of health professions here? Crickets. So no one. If there is someone from the School of Health Professions, or if there is another person interested in this slide, trying to sort of wrap your hands around there, I think is fascinating. And some of the things I mentioned the school is because they have one or two professors there, and they have a methodology called nominal group technique that will allow you to examine and piece out on each of those spaces to see what are those it domains. Because before you can run an analysis or regression or whatever matrix, you need to know what to put into that analysis. What the nominal group technique has anyone heard about the terminology? Nominal group technique? Okay, so this is one of those things that if you have a hammer, I mean you treat everything like a nail, correct? We have used nominal group technique in the areas and spaces where we don't know where the dimensions are. So for example, who is the greatest surgeon? We can ask 10 different people and we'll get 10 different answers. But if we use this technique to say, what are the specific qualities of a great surgeon? And we ask their patients, their peers, their nurses, the OR techs, and so forth, there is going to be bubbling of things, of domains that you never have thought about it. So I'm just wondering if that may allow for someone to sort of dive into that area. We have used that to examine what are the characteristics of a great teacher in the medicine world. And it's not what you have expected.
And Carlos, methodologically, correct me, but as I understand, it's a process of doing what would be like a traditional focus group, engaging a group, identifying themes, drawing out those themes like on a whiteboard or a flip chart, but then asking each individual in the group at the end, rank order, which of these are of greatest importance to you. So I think part of what I've heard that people like about this is sometimes in focus groups there could be a dominant voice, so you hear someone that just over talks, and then other folks might not speak out as much, so that is perceived as the representation of the group. And it also gives some mathematical quantification to some of the qualitative themes that emerge in terms of giving rank ordering and weighting.
If you know someone who is very interested, let me know, and then I'll connect you with 2 or 3 people and send you a couple of papers that we have put together.
Yes. And a good example, I mean, Jessie Merlin used this really effectively when she was on her intramural K and trying to rank order for chronic pain, the components of an intervention that participants would really want, like what really mattered to them, and was able to kind of use that and not just get the global feedback that you would get from a focus group, but then actually get the weighting so that she could really say, this is what makes sense for me to focus on. People, while they talk about 10 different things, here are the 3 that they really felt were the most important for them in terms of managing their chronic pain. So it was really effective in guiding intervention development for Jesse.
Nominal group?
Nominal group technique, yeah.
Nominal group NGT. I think that may be important too, just considering the fact that there are a lot of factors listed here, and you may not have the sample size to support looking at all of those factors individually, so it may be beneficial to find some common groups.
Yeah.
Wonderful. Great, thanks everyone again. Sorry for the over-ambitious scheduling, and appreciate you guys understanding, but we want to make sure we have enough time for everyone to really get good discussion and feedback. Happy Friday, the 13th.
I can't, so that was, oh, Sandy, oh my God, I can find out. Are you looking for next Friday? Yeah. And Matt, are you looking for next Friday? Okay, I'll find. Yes, you are. So I'll ask you around all of that.
Sure.
I'll be right after the bus. He's looking at that here, trying to like, you have people on it. Okay, sure. No, I'm trying to get some guys. You thought you would join Charlie. Absolutely. I know that.
Check this out. Which one's yours? This one? I guess let's take this out too.
But it sounds like it's going to be really nice and well done. Next week,
Yes, do you want to try this? I need 2 people, so I'll email you. I think, okay. Yeah. Really cool.
I was about to say, I'm going to be hesitant going back to that, but
Yeah, absolutely. Did you ever got back to me about the candidate meeting? So I held FOT 803 from 12 to 5 today. She never let me know if I needed to shorten that. She did mention that there was one this Friday. She wanted the trainees. Okay, so I should use that.
yeah, thank you.
Oh no. Sorry, Justin.
Thank you all for meeting with that.